pulmonologist. I work in the hospital, Sramban Tuanku Jaafar, and we know that COVID cases are increasing, especially in Negeri Sembilan. I'm not sure whether we're competing with anyone, but I just want to say that let's be safe. So I don't have any encumbrance. Okay, this is where I did my attachment in Sir Charles Gardner Hospital in Perth, and a little bit of affiliation to the Paran Institute of Neurological and Translation Science. So now, very quickly, I just want to tell a little bit about the background. Sleep disturbance in MND or ALS patients, and I'll be covering a little bit of leg cramps, fasciculations, immobilization, nocturnal pain, restless leg syndrome, and periodic limb movements in sleep, parasomnus, insomnia, all this which causes sleep disturbance in a patient with ALS and MND, and a little bit of these features in sleep study that usually we will look at that can come about in this kind of patients and how we diagnose them. Right. A little bit of background. All of us are aware of MND. It's a progressive disease. It's incurable, and it perpetuates muscle weakness and disability, and eventually death. Prevalence is about 1 to 3 cases per 100,000 population, and there are some sporadic and familial cases have been reported. Okay, I'm just going to go very quickly into what it does. What are the sleep disturbances that we get in MND patients, right? Let's look at leg cramps, right? And these leg cramps are quite common, and they usually occurs at night. They affect the lower limbs, and it's the prevalence is very high, can go up to about 92%. And we notice that the kind of patients who have got more of this would be patients with got spinal manifestations. And why it occurs is because of some discharges over the anterior horn cells. And we notice that these discharges apparently, they have got some remission after an active stretching of the limbs, right? So if you have patients who are telling you they've got leg cramps, I think probably you may want to consider stretching them a little bit, right? And of course, when these kind of patients, they come for follow-up, we need to actively ask them whether they have the symptoms or not, right? But the other thing that you need to consider would be, we do some blood tests and we look at whether patients dehydrated, because these are all the treatable conditions to reduce the leg cramps. We also look at medications the patient has been taking, for example, like statin. And if so, I would suggest to stop them because they can contribute to leg cramps. Of course, one of the immediate improvement that you can remedy these patients would be a bit of stretching. And mexiletine has been tried. A couple of other medications also have been tried, like baclofen and vitamin E and some amino acids, but unfortunately they don't show any much of improvement. Of recent, but this is for non-ALS patients, quinidine, an anti-malaria drug, they have used it with a good success, but however, they've got a lot of side effects and need to be careful of that. And of course, not only leg cramps, they can also have fasciculations, which means that twitching. And mainly we regard this because of the degeneration of the lower motor neurons. Immobilization, right? So we know that normally, even when a normal person sleeps, they tend to change their posture at an estimate of about 1.6 turns per hour on the average. But for patients who have got MND, ALS, there is a reduction in the motor function. Changing of these positions may be very difficult, and I can imagine that they have a great distress by the fact that they can't turn as much as they should, right? So that causes a nocturnal discomfort. And also pain and a lot of dependency on the caregivers, right? So when the patient can't turn much on the bed, so they are at risk of getting skin lesions. And of course, you know, we thought that once that those who you know, who don't turn much on the bed, they tend to develop bed sore, and it holds true for patients of ALS as well. I'm going to touch a little bit of pain. Okay, now we know pain is the fifth vital signs that we have in our hospitals, isn't it? Anyone who comes to the hospital, besides taking their blood pressure and saturation, pulse rate, and all that, we do also ask them about their pain, whether you have pain from a score that we have 0 to 10, right? So pain is not something looked forward by patients, of course. So what happens is that when you have pain, especially at night, it disrupts sleep. But it's the other way around too, which holds true. That is, if you don't sleep well, you have pain, or the pain that you have, it gets exaggerated, or it promotes occurrence of pain. So they are interrelated. If you don't sleep, you get pain, and also pain doesn't allow you to sleep, right? So we look at what is the cause of the pain. It could be due to muscle cramps, spasticity, or even immobilization. And we know that our MND patients, they lose a lot of muscle bulk. And once they do that, the bone becomes vulnerable to pressure. Hence, they can have pains coming from there. The kind of pains that we look at would be can divide into nociceptive pain, neuropathic, and central sensitization. And the reason why we divide all that is because the treatment is a little bit different. How do we differentiate? Nociceptive is clearly localized, and we know the mechanism, the cause is clearly known. For example, like wound, bed sore, all that will produce nociceptive pain. And the neuropathic pain is the pain which caused by neurology, meaning that it is described as burning, tingling pain, and dysesthesia if evoked by tactile stimulus, right? And of course, the other kind of pain is the central sensitization. It is actually non-neuropathic. It is almost permanent, and obviously, we have a nociceptive trigger. So the nociceptive trigger starts it off first, and then it lingers in the central nervous system, right? So what it is, it's abnormal nociceptive response within the central nervous system, right? Central amplification of non-painful sensory inputs, which means that it could be just a small touch which been amplified, and then it's within the CNS, it goes and it perpetuates, right? That is defined as central sensitization. So it's not easy to treat, and we don't know that much about it, but it is something that we need to ask, right? Because the studies are still lacking, and treatment recommendations actually does not differ that much. It is actually the treatment is actually based on still experience rather than evidence based. So nociceptive pain responds to adequate preventive measures. For example, let's say we're able to reposition the patient in a certain posture. Like they always tell that if you like move, try to move the patient like every 2 hourly, or if you're able to get them some special mattresses which reduces the pressure points, right? That will be great. Worst case scenario, you may want to give a little bit of oral medications like paracetamol or anti-inflammatory medications like like ibuprofen and all that. But mind you, these are not supposed to be given on a chronic basis because they do have their own side effects. If let's say the pain is not entirely relieved by NSAIDs, then you may want to consider some opioids. But then again, it has to be titrated very well. I'm sure the palliative counterparts will be able to know will be able to help us how to manage patients with opioids. And of course, for the neuropathic pain, you have gabapentin and pregabalin or tricyclic antidepressant can be offered as well. All right. Spasticity and cramps, they are synonymous. They come hand in hand. But spasticity, they respond well to central muscle relaxants like baclofen. They do have a little bit of sedative side effects, and the best would be if we given at night. So we know that pain is very common, and the likelihood is that the pain will definitely disturb sleep, right? So in order for them to get better sleep, so we definitely need to address this pain, right? They can impact quality of life, and then in advanced diseases, this is one of the reasons why many of patients may ask for assisted suicide. But of course, this one needs to be addressed. So we should not allow the patient to suffer in pain. If this is clearly sought out early, it should be addressed, and it is mandatory to get a pain relief, right? I'm moving on to RLS and PLMS. RLS is the abbreviation that I use for restless leg syndrome, and PLMS is periodic limb movements in sleep. How do we diagnose? We diagnose restless leg syndrome by looking at these 5 criteria. Do you ask the patients verbally as to whether they have an urge to move the leg? Do they have this unpleasant and painful sensation in the lower extremities, and that they didn't have the urge to move the leg, right? We have to look at the onset of it. Usually it occurs at rest or during inactivity. The symptoms are worse at night. And of course, when it occurs, if you tend to move it, you feel good about it, right? And of course, these symptoms cannot be explained by other medical conditions. So when when a patient fulfills all the above criteria, then we can say that the patient has restless leg syndrome, okay? And the prevalence is about 10%. And of course, we have a wide severity. It can between a milder symptoms to a profound impairment of sleep. And we have noticed that it is slightly more common in ALS patients as compared to a control subject, right? So this means that we need to look harder, right? And the prevalence can be as high as about 25%, right? They have, as compared to general public, the patients with, ALS patients, they tend to have a shorter history of complaints, right? Meaning that they may have the disease just for a couple of months. They may already start having what we call as RLS. So this history needs to be elicited from these patients, right? So on the contrary, what happens is that the sensation of to move your lower limbs and all that gets hampered if the patient has got problems with mobilizing. For example, let's say we know that these patients' disease are progressive, and they will come to a point where the movements will be very much hampered, and this progression of reduction in movement actually causes RLS, right? Of course, it's associated with motor impairment, and these are the patients who have got difficulty in turning in bed. Can you imagine? One of the relief for RLS is to move the legs, right? But unfortunately, ALS patients have got difficulty in moving, and hence the exaggeration of RLS, right? Why it occurs? Some postulations that they'll have some sensory fiber involvement. So again, the symptoms, has to be asked when the patient comes to see us. So when we diagnose the patients of RLS, what we do? So what usually I will do is that I will start investigating the patients by taking some blood. We notice that patients who've got iron deficiency, especially serum ferritin, which is lower than 100 micrograms per liter, we need to correct it, because I noticed that iron deficiency causes RLS. We may also want to consider some dopaminergic medications as ropinirole and pramipexole. But while giving these two medications, you have to look at augmentation. And I would prefer this to be started by someone who's an expert in this. The reason why, because when you start these medications, you tend to worsen the RLS. But the person who has experience in this, you should be able to know what to do. Pregabalin and gabapentins, we can try it at first. And of course, if it's going to get worse, then you may want to consider some opioids. Definitely a referral, palliative care would be great. And how do we diagnose this? We need to do a sleep study. And this sleep study or polysomnography, we have some index that we look at. And if this index are more than 15 per hour, and sorry, more than 5 per hour, so we can diagnose the patients of having PLMS, right? So now the term that I used is RLS and PLMS. So what is the difference between these two? So RLS occurs when the patient is awake, and PLMS occurs when the patient is asleep. That's the reason why we have to do a polysomnography. So polysomnography will collect all the data during the patient is sleeping, and that when you examine, when you look back at, when you go through the data, and if that is we have an index, and that index, if it's more than 5 movements within or more per hour, then we know that the PLMS is present. So one thing I want to note is that although you have PLMS, what do you call that, captured in your polysomnography, it has to translate into an arousal, meaning that if you notice that the PLM index is above 5, and if you're very happy, you may say like, okay, I've successfully diagnosed him of having a periodic limb movements in sleep, right? But if does not translate into an arousal index means that you know, there's a difference in the patient's brain waves while the patient is sleeping by means of EEG. When you do an electroencephalogram, so we look at the stages of sleep. So if it does not translate into disturbance in the stage of sleep, then of course we assume that it doesn't really have a direct impact on his sleep per se, right? So that's what I'm trying to say. PLMS not necessarily will cause increase in arousal index. And here we notice that it only arousal index is only about 3.6. The usual arousal index we look at would be 20 to have a significant disturbance with sleep, right? So we still don't know about the rate of prevalence. And is there an isolated PLMS? We are not very sure either. So why it occurs? It reflects the, it is actually due to some spinal cord dysinhibition and hyperexcitability due to degeneration, right? I'm going to go to parasomnias. So what are parasomnias? So these are abnormal movements, behaviors, which can translate into emotions as well, which arises when patient is about to go to sleep or while they were sleeping. So this is basically discontrol between sleep and wake boundaries, right? So when a wake and sleep boundaries have been crossed, and if there is a discontrol there, then we know that the patient has got parasomnias, right? So it is also regarded as dissociated sleep stage. characterized by partial arousal from REM or non-REM sleep. Usually we divide them into two large cohorts. One is non-rapid eye movement sleep and rapid eye movement sleep, and we will try to find out where is it coming from. There is no evidence to support the non-REM parasomnias are frequent. The non-REM parasomnias are like sleepwalking, confusional arousal, or night terrors, or power nocturnus. This is night terrors. So these are lumped together in non-REM parasomnias, whereas REM parasomnias are like RBD, characterized by persistent phasic and tonic muscle movements during REM sleep. So how we diagnose all this? Again, we have to do polysomnography, right? During polysomnography, we have a video EEG as well. So we look at all these bizarre movements which takes place during the stages of sleep, and whether it occurs in stage 3 of sleep or stage 4 of sleep. Okay, that will gives us an idea whether it's a non-REM parasomnias or REM parasomnias, right? Why is it occurring? Very vaguely, we know that possibly due to some pontine spinal pathology, and how RBD is manifested as a dream with the enacting behavior. And of course, we know that the RBD is associated with Parkinsonism, and Lewy body dementia. And we also noticed that RBD or REM behavior disorder is actually closely associated with a couple of diseases. And this is very familiar to all our neurologists. And once you diagnose all that, we need to address it. We need to treat it, right? So what we will do is that we need to know whether it occurs in ALS patients, but the literature is very scarce. We don't know how many of these patients in ALS has got RBD, but this is something that we always need to consider. If the ALS, in ALS patients, the RBD is present, then of course we have to institute the treatment. Because why? If you're not going to treat that, and they can injure themselves. And we should also look for sleep disordered breathing, for example, sleep apnea, which later Dr. Ian will be telling us. So if the patient has sleep disordered breathing, and the patient also has an RBD as well, of course, one of the treatment is to for RBD would be to treat the sleep disordered breathing first, right? Because we noticed that once the sleep disordered breathing is taken care of by means of either a CPAP or any other non-invasive ventilation, so we noticed that the RBD actually improves. In worst case scenario, a pharmacotherapy may be considered, like a clonazepam or melatonin, right? I'm going to talk a little bit about insomnia. It's a very important subject. Insomnia, actually, even it is not well addressed in normal individuals, not to mention in patients with ALS. So what is insomnia? It's a chronically non-restorative sleep, which actually worsens the daytime performance. What are the causes of insomnia? The causes of insomnia can be due to sleep disordered breathing, can be due to a chronic aching or nagging kind of a pain. It can be due to some cramps. It can also be due to restless leg syndrome. Yeah. So all this can deprive the patient of sleep. So there are two types. One is the sleep onset insomnia or sleep maintenance insomnia, which means that sleep onset insomnia is, you have difficulty in falling asleep, or if already gotten into sleep and you can't maintain that sleep. For example, you tend to get up in the halfway, and then you try to go back to sleep, and you can't do that. So we call it like sleep maintenance insomnia. So immobilization likely to impair sleep quality and hinders the patient to turn around, as I mentioned earlier, right? And of course, they also have this inability to scratch because of a decrease in motor function, and that can actually cause insomnia, right? They have such an itch in the leg, but you can't do anything, but because you can't move around to scratch it, that actually makes you to stay awake at night, right? It's very common, but of course, we are not really sure of the prevalence. Um, so, and insomnia can also be due to the stresses within, meaning that the anticipation into the progression of disease, the anticipation that, who's going to come and help me, and all that. So that one needs to be addressed, right? Otherwise, it's going to be very detrimental. So what do we do? Benzodiazepines and opioids have a role in insomnia, but I think we need to ask the experts regarding the usage of these medications, because of course we're looking at tolerance and dependence. So usage is for both these opioids and all, that's indicated, especially if respiratory failure is present and mechanical ventilation is not consented for, if it's not feasible, or going to be terminated at person's will. Meaning that what I'm trying to say is that we resort to only these medications if everything else actually fails. And it's not to be considered as a sedative, as an all-purpose medication for insomnia at the earlier part of the course of disease. So it should be reserved for later part of the disease, right? So insomnia could also be aggravated, as I mentioned earlier, by sleep disordered breathing. And then we need to investigate as much as we can the causes of sleep disruption and also pain, right? I'm almost coming to the end. Before I go into the polysomnographic or hypnogram, okay, and benzodiazepine is also reasonable option to be considered for to alleviate insomnia if short-acting ones are considered, right? Okay, so let's look at the several features in a sleep study which tells us that which usually occurs in our MND or ALS patients. Here is a hypnogram. This is what we are, myself, in Dr. Ian and a couple of us will see when we put the patient on a sleep study. So above, we can notice that is this bars, and this is the horizontal black bar over here. So this is REM, and you notice that the REM actually, becomes longer the second part of the night. And the other thing I want to bring attention to is your CO2, your carbon dioxide. So what happens in that, as the night it advances, we notice that the patient's CO2 goes higher and higher, right? So high CO2 is not good because it contributes to acidosis. It contributes to rapid breathing. So when we do a hypnogram, when we do a sleep study on our MND ALS patient, these are typical features that we look at. So we also notice that these patients also, they have got a lot of sleep fragmentation. So what is sleep fragmentation? Sleep fragmentation means that you can see they constantly move into stage. These are the N1, N2, N3, and a REM sleep. So they constantly move. So we can see the bars going up and down, up and down. So this is what you call as fragmented sleep, and that is not good for any patients or even MND patients, but because that's going to have a sleep disturbance that they get very tired during the daytime. So we noticed that the usual N3 and REM sleep is supposed to be about 20%, but it's markedly reduced in patients with ALS, right? And then over here, we noticed that the AHI, apnea-hypopnea index, is about 83.8. That is, this is the amount of time they actually stop breathing per hour. The normal is about 5, and this patient has got 83. That is, very, very, puts the patient in severe. And we look at the CO2 is also, when it goes up, it's about 54. Our usual CO2 is between 35 and 45, but this is end-tidal CO2. End-tidal CO2, we tend to take it a little bit higher. We like to take it at about 55 usually, but of course, we're going to leave it as such. It's going to go higher, right? So this is what happens if we put the patient on some form of a therapy. We notice that the patient's fragmentation actually improved, right? We also noticed that the REM actually started occurring a bit early. And of course, the substantial increase in REM and non-REM sleep once you start treating the sleep disordered breathing, when later Dr. Ian will be pointing us out. You look at the improvements in the apnea-hypopnea index, and we notice that the saturation also improved once you start treating patients with CPAP machine and all that. So with that, I thank you.
I'll take this opportunity to thank the organizers, MND Society of Malaysia, Tan Tock Seng Hospital, and the I think ALS Society of Indonesia for allowing me to share some of my experience in managing ALS patients, in particular using non-invasive ventilation. This is the second part of the talk that I've actually presenting for a series of webinar. Okay, and I think we can start, right? So I've got nothing to declare, and the photographs and the videos I'm going to use today, it's all consented by my patients, and this is the rough outline of the talk today. I'll go into maybe 1 or 2 slides on ALS and its symptoms, especially on respiratory symptoms. Then the main bulk of the talk today will be on NIV. And after that, we'll discuss a little bit on what are the factors that affects tolerance and adherence to the treatment, what are the solutions, maybe end with 1 or 2 slides on telemonitoring. So this is where I work, University of Malaya Medical Center. It's at the heart of KL Metropolitan. Now, as we know, MND or ALS itself, patients with degeneration of these neurons, right? They have muscle weakness of the limbs. But what interests respiratory physicians like us is in particularly the respiratory muscles. And one of the main respiratory muscles that we are extremely interested in is the diaphragm, because diaphragm itself helps in the breathing, especially during the night when the patient is asleep. The other muscles that also interest us is the bulbar muscles. Why? Because it controls the phonation, the swallowing, and also it helps to maintain patency of the airways of the patient. So when the patient has respiratory muscle weakness, of course, it can lead to cough impairment because you need a good lung volume to provide a good cough. So when the cough is impaired, then there's retention of secretions that can lead to lung infection. The fourth thing that we are interested in is sleep, which has been presented very well by Dr. Raymund earlier on. So to make things very simple, basically we are interested in the muscle strength of these respiratory muscles and the overall lung function. And of course, sleep, not forgetting about sleep. Okay, so patients with ALS, a lot of times they come to a doctor or they are being referred to us. Like neurologists see them because of limb weaknesses. Some of them may have bulbar symptoms. But little that patients or general physicians know that actually only around 20% of ALS patients are aware of their respiratory impairment. And this is the data that has been shared in overseas long time ago. And I'm sure if it's the Asian population, the figure will be even lower. Some symptoms like orthopnea, sleep-related symptoms, for example, the patient is feeling sleepy in the morning, unfresh, morning headache, very poor sleep quality. All these symptoms are really under-recognized. Yeah? And when the patient does complain about breathlessness with or without exertion, it actually signifies that it could be a late feature. So when ALS patient, when we examine them, apart from a very shallow breathing, probably the breathing is a little bit rapid, some of the other physical findings you can see is the usage of accessory muscles. And at a more advanced level, you do see paradoxical abdominal movement, and some patients may even have a weak cough. One thing that pulmonologists or chest physicians like us are very interested and very eager to detect this as early as possible is something called hypoventilation. Basically, it's just meant by breathing very shallow or too slow to unable to meet the lungs is unable to meet the oxygen demands of the body. With the low oxygen levels, there's increase in carbon dioxide and blood acidity. There are few effects that you can see because of the elevation in blood acidity and carbon dioxide. For instance, like hormonal effect, they can cause impairment in glucose tolerance. Neuronal effect, sometimes it triggers the sympathetic tone. That's why some patients with hypoventilation, they may develop tachycardia, especially at night. And vascular tone as well, it can actually affect the constant low levels of oxygenation actually can lead to a pulmonary hypertension, which we are extremely worried about because when there's a pulmonary hypertension, generally the outcome will be rather poor. Some symptoms that you might want to screen your patients, they are rather not really specific, but do screen using symptoms like this routinely, whether the patient is sleepy in the morning, whether he or she is out of breath, feeling lethargy, feeling tired. It depends on the severity. The more severe it is, then the symptoms will be more obvious, okay? Using PCO2 levels, if let's say the PCO2 levels that you obtain from your blood gases during a week, if the levels are high, normally it suggests that it's rather late and the prognosis would not be that great. Yeah. Then the other thing that we do to assess our patient is this lung function test. And basically for ALS patient, generally there are a lot of abnormalities found in lung function testing. In the past, it has been demonstrated that approximately, for ALS patient, they will have a 3.5% decline of the vital capacity each month as the disease progresses. And when in the past, clinicians has used symptoms as a way to evaluate their patients, it has been demonstrated that up to 50% of the patients with ALS with respiratory impairment are missed. So what we suggest and the guidelines suggest is if the patients present in the early stage, you may want to use, you may want to measure the respiratory muscle strength, which is more sensitive, but at a later stage, vital capacity might be a more reasonable test to do. So now we go on to NIV, okay, the main part of the talk today. So has anyone wonder why NIV is useful for ALS patient? Basically, the concept or how it actually works is this principle is based on when the ALS patient is hypercapnic, the NIV itself is a form of assisted ventilation that helps to unload the CO2, especially at night because it's used nocturnally. And when you use NIV nocturnally, it improves the ventilation. indirectly in the morning itself, it increases the ventilatory stimulus. Okay. The other effect that has been shown in some study is NIV could help to improve the lung compliance. Now, some of the evidence usage of NIV in ALS patients has been demonstrated. For instance, the survival benefit, it has been shown to improve survival benefit in especially non-bulbar patients. It also improves the quality of life for patients with ALS, cognitive function as well. To a certain extent, there are some papers to show it helps to slow the decline in the lung function. There are various guidelines out there that you can refer to. There's to help you to initiate NIV for your patients. There's these German guidelines, the latest one that is available. With the Canadian, there's a UK guidelines from NICE, and the first guidelines from the American colleges in 1999. So basically, three things to remember. All guidelines are based on symptoms, which have been mentioned earlier on. Some symptoms of hypoventilation, you screen them, or using blood gases. Okay, for instance, any evidence to suggest hypoventilation or nocturnal hypoventilation, or abnormalities in your lung function, which I normally use the recommendation from the American colleges using an MIP of less than 60 cm water or the forced vital capacity of less than 50% predicted. So any of this, if it's positive, you may want to discuss with your patient and consider initiating on NIV early. Now, for NIV itself, it's basically a positive pressure ventilation. Some major elements that involves is like ventilator, the modes, the respiratory circuit, the interface, the monitoring system, and of course, the respiratory cycle itself. They have these trigger, limit, cycling, this concept of understanding, which I'm going to go into probably in the next slide. Now, the ventilator BiPAP, we're talking about BiPAP, right? Non-invasive ventilation. There are many models available in the market. On the photos on the left are the basic models, whereas the one on the right are the higher end. They both works equally well. It depends on the demand your patient requires. Generally, the difference is the higher end models have more ventilation mode. They last longer because they have an internal battery. They are turbine driven, so you can operate them round the clock compared to the ones that is blower driven on the left. And of course, the cost of the higher end models are higher. Yeah. So now this is something that's very basic, and I think we should understand this before we embark on other aspect of NIV, managing NIV. So once the assisted ventilation or assisted the assisted ventilation from the NIV itself, once the patient breathes in and out, is called one respiratory cycle, inspiratory and expiratory. And it requires a trigger to initiate it. The trigger can be from the patient or it can be from the ventilator itself. So once there is a trigger, if you follow my cursor, there will be inspiration. And once it reaches a limit, that is where the cycling happens before the patient goes into the next respiratory cycle. So this is what meant by trigger, limit, and cycle. Two breath types are available, either spontaneous or assisted. So the term is self-explanatory. If it's a spontaneous, means that the trigger or the cycling comes from the patient. And if it's a assisted, that means the trigger is coming from the patient, plus minus from the ventilator. Cycling itself is from the machine. Common modes of assisted breath is like your spontaneous time or your pressure control. The difference between them is the pressure control, the level support of it is higher, because for pressure control, the length of the breath is based on the inspiratory time set by the operator. Now, if this seems to be a bit confusing for you, it's a bit difficult to understand. I'll have a later pictorial to help in the understanding. For time breath, the cycle, the trigger, everything is actually controlled by the ventilator itself. So from this assisted breath, there are two types of assisted breath. It can be a pressure or volume assist. Okay? So pressure assist means that the independent variable is pressure, so it's pressure-based, make it simple. Volume is volume-based. And the difference between them, which one to use, Stefano Nava did a study long ago in ventilating patients using either pressure or volume assist. And he has demonstrated that there is no significant difference on respiratory physiological effects between both modes. Now, the question is now, which one should we use? For NIV itself, we encourage to use pressure assist. The reason why it has good leak compensation. Whereas if you are using a volume assist, when the mask is poorly fitted, there is leaks from the mask. Imagine the leak will reduce, that leads to a reduction in the flow, and there will be a poor leak compensation, and the ventilation itself will also be affected. Now, here is a poll. I'm not sure why that comes up 100%. If you, I've allowed everyone 10 seconds, if you can use that code and vote on the poll. Which pressure ventilation would you choose if you're going to initiate your patients on NIV? Would it be spontaneous mode, spontaneous time mode, or spontaneous time with WEPS? WEPS is volume assured pressure support. Spontaneous time with WEPS and AE. So 10 seconds, yeah. Wow, okay, great. Yep. Great, actually I can end my talk prematurely. And yeah, I think these modes are all quite acceptable. It's good to see that no one actually chooses the time mode. Wow, okay, good. Okay, yep, let's move on. So, this is the slide that I'm talking about. Now, to help to understand, follow my cursor, there is a patient cycle, the blue line, and the gray line, which is a machine cycle. So in the S mode itself, like I've mentioned, is everything patient trigger and patient cycle. So that's why if you look at the blue line from my cursor, it's all patient trigger and patient cycle, right? Simple. Now for the ST mode, okay, if the patient trigger is the same like the S mode, but if the patient does not trigger, there is where the machine will kick in, and you see it changes to a gray line where the cycling itself is also determined by the machine. Simple, understand? Now for PC mode, if you can see the gray, the line, the cycling is all grayish, so it's machine determined because based on the set inspiratory time done by the operator. And for T mode itself, is the machine will trigger with the rhythm of the configured breath rate. So the patient is not involved at all. That's why T mode is rarely used because it's really uncomfortable. ST or S mode is the more common use mode. So now the next question is between S mode and ST mode, which one to actually use? So this Belgium group actually did a small randomized control trials in ALS patients comparing S and ST mode. So in a nutshell, just to summarize, they have demonstrated that ST mode is a little bit superior because there are some significant results in the overall sleep quality and improvement in the oxygenation, improvement in respiratory events. But however, in terms of arousal and awakening index is similar between both modes. Yeah. So you may want to consider, you can probably start with the S mode, and if your patient's rate or ventilation requirements are not met, then you can actually move on to ST mode. But if you want to make it simple and streamline your services just to avoid confusion, you may actually start with ST mode as well. We're not going to go into double limb circuit today because double limb circuit is used more in the ICU, or probably Dr. Chan, he's used a lot of double limb circuit, okay? For us today, we're just going to concentrate on single limb circuit, okay? Because NIV, for convenience and also for ease, we use single limb circuit. There is an active circuit or a passive circuit, right? So the single limb circuit, as you can see here, before I go into that, the mask itself, you have to be familiar. There are two types, which is called the vented mask or the non-vented mask. So the certain brands itself, they actually, to ease identification, they have actually put the non-vented mask as a blue elbow, like here. And the vented mask, you can check there's some exhalation ports up at the top of the mask or somewhere in the mask. Okay, that's the difference. So this is a passive circuit with a vented mask. That means the exhalation is via the mask. Whereas this is a passive single limb circuit where the patient uses a non-vented mask. So there must be an exhalation valve, right, to prevent rebreathing. So the exhalation valve is in the circuit itself, all right? So some of this example of exhalation valve that you can see commonly we use in Malaysia is the first one. Sometimes if you work with me, I use a lot of whisper swivel, okay? The two exhalation valve, sometimes, not that common, sometimes, okay? Yeah. So now we have actually not going to discuss about dual limb circuit. So single limb circuit, so whether it's active or passive, right? Some people might worry that if you use a passive, there will be a CO2 retention. So in the past, there's two good studies have proven or demonstrated that active and passive circuit are equally effective in avoiding rebreathing in NIV. In fact, Eliza de Matthias in 2018 has used both circuit in invasive ventilation for patients with ALS, and she demonstrated that both are equally good and the same effect without any risk of CO2 rebreathing. So basically, single limb circuit passive is suitable for chronic stable life support ventilation and NIV. We encourage because it's less complicated and easy to manage, right? Okay. Now let's go to the mask itself as we go more proximal, right? This mask interface is something of my interest because this is something that if we don't sort it out, it will be a big issue. So a lot of questions is there one best mask, or how do we decide which mask to use? This is some concern that is always popped up from my patients, whether this mask is good at delivering ventilation, whether it's the leaks, whether it's comfort or not, right? Now, some masks that is available in the market, there is nasal mask that your home care provider will introduce your patient. This is the full face mask. These are all the nasal mask. This is the vented mask. Okay, you can see here. These are all actually vented, yeah, vented. You see the arm is not blue color. And this is a quick release button. So in terms of mask, as a physician or the prescriber itself, there are studies that have been done that has shown that in terms of different range of masks, the clinical efficacy is similar in improvement of respiratory parameters. So now then the next question is which to use. I would say let your patient try it out and see which your patient feels comfortable with. That will be the mask, okay? But if the certain things that to look at, if your patient would prefer a less bulky mask, something that is less claustrophobic, something that he can speak, or maybe your patients would like to cough in the night, then the nasal mask would be more suitable. If your patient would like something that's off the nasal bridge here, then you may want to use a nasal prong or maybe a mouthpiece for those very chronic ventilation patients. Helmet and total face are rarely used for chronic. It's more of like acute setting, okay? Some tips for mask fitting. This is how I do it. I normally start off with a smaller size, not to over tighten the mask. The adjustment of the mask can be done two places, either at the strap or the headgear. I think the mask has a headgear. And once you have fitted the mask, it's important to remember these 2 points that I mentioned today. Ensure that the cushion is not crushed against the face. You can see the cushion. Some of them is either silicone or gel. If it's crushed against the face, that means it's too tight. And this is a very important part that I've always seen it happens. Whether you can tell the caretaker or anyone that's taking care of the patient, do not block the exhalation port if there's an exhalation port, whether it's a mask or at the circuit, okay? And direct the port away from the patient. I normally do mask fitting before I start, done at a sitting position. And once they're comfortable, I lie them down, I start the machine, allow them to adapt. And when I'm doing it with a caretaker, sometimes foreign caretakers, they may not be so familiarized. I have the option of mark the headgear with a permanent marker. So if the caretaker prefers to adjust the strap, he or she will know where is the location of the Velcro that should be applied every time the strap is put on. And use this, remove the mask by a quick release clip, and always practice a fit mask then strap technique. Okay, I'll demonstrate this later. Fit mask then strap technique, not the other way around, not strap and fit mask. And last is you can do a leak test. I'll demonstrate this later on, yeah. Yeah, this is available by your home care providers. That means vendors or distributors. If you want to use that, I normally address them as home care providers. There are fitting gauges, guides to help you determine the size of the mask that your patients are suitable for. And this is what they call the fit mask then strap technique that I do. Okay. So this is not an ALS patient. This is an OSA patient. Yeah. So I normally hold on to the mask here. Okay. Before I strap the patient on. As you can see, I move a bit further. So tighten both sides using similar strength. Make sure it's not too tight. Make sure it doesn't touch the eyes, above the lips. Okay. So then I will try to initiate NIV, but before that, I normally explore the patient's view and also the level of caretaker, the level of social support at home. Some things that I also explore is like the age, the nutritional status, how weak is the patient, whether the patient has bowel function impairment, cognitive function, because all this will influence the adherence of NIV. Some useful ventilator parameters for everyone. So for those who intend to start, these are the 4 basic things that you can see on the NIV monitor that you can use. So VTE means by estimated tidal volume. It's the volume of air on each breath is estimated. Minute ventilation is MV. It means the total amount of air when the patient breathes out in 1 minute. It's the formula from total tidal volume multiplied by a respiratory rate, which is the number of breaths per minute. Peak inspiratory pressure is the highest pressure in the chest and the circuit. So these are all on the screens of the monitor of the NIV that you can check the results or check the parameters once the NIV is running. Yeah? Now this is a quick initiation guide, which I also applies. This is from Dean His in 2009. Select your patients carefully, explain to them about NIV, choose the mode before you start. Most common mode, you want to start with ST. Choose the appropriate interface, make sure it's comfortable, allow your patients to feel. So you can actually on the machine and put the mask on the patient's hand to allow he or she to feel it, to adapt before without strapping the mask on first. Once she or he is comfortable with it, you strap the mask on, and you can actually start with very low setting. For instance, a minimum of PEEP of 4. You can keep the pressure support at 4, and then you allow some time for the patient to get adapted to. Once he or she feels comfortable, by looking at the parameters that I mentioned on my previous slide, your volumes, your minute band, your respiratory rate, you can adjust accordingly to increase the pressure support to achieve your targeted parameters that you want, right? Then if, let's say, if you're titrating in the lab or you're doing a remote titrating like me, each day you will check on the results. If the volumes are low, you may want to increase your pressure support up to a level where all these parameters has achieved and the patient is still a little bit hypoxic. You may want to add some supplement oxygenation. For ALS patient, I rarely use a PEEP more than 8 unless the patient has some form of obstructive upper airway disease. The IE ratio that I use is normally around 1:2 or 1:3. This is a slide, maybe some of our young respiratory doctors who want to take a snapshot. This is a recommended or proposal setting for NIV in ALS patient. Just like I mentioned, you can start with low PEEP, low pressure support. And as you go by, if you need higher pressure support, you can go up to 10. For bulbar patients, be very cautious about this. They may not tolerate well, but you may want to increase the PEEP a little bit if, let's say, they are not too good or no PEEP. But I generally have not tried like high PEEPs for them. A lot of the bulbar patients, the severe bulbar patients, they don't really tolerate well. Yeah. Inspiratory time, this is the recommended 0.8 to 1.6. My personal preference is around 1.2 to 1.6, depending on each patient itself. Yeah. So while I strap them on, then I'll talk to the patient or the caretaker. I'll troubleshoot this. I talk about the device itself, how you turn it on, off, standby mode, the cleaning of the machine, the filter, and the servicing. Okay, this was before the COVID pandemic. Nowadays, it's done by my home care provider, which actually assisted me a lot. They are doing the hard work on the ground, whereas I'm just sitting behind the computer and just, changing some of the settings every day. Yeah. So they talk about the interface. They brief the patient in terms of the leak, the tubing, yeah, and ensure the comfort of the patient. During the adaptation, I know the home care providers will ask whether how is the patient feeling in terms of breathing in, breathing out, whether it's too dry, the temperature of the air that's from the NIV itself. Yeah. So this is, just ignore this, just imagine that this is a circuit itself, right? Circuit itself, if your patient is on double limb circuit like this, or there's an active humidification here for those who are on home ventilation on a tracheostomy, for example. NIV, a lot of times may not have alarm, but if like tracheostomy ventilation, alarms are set. So it's worth mentioning here, 2 alarms that I think we should be aware of is the low pressure alarm and the high pressure alarm. Basically, when there's low pressure alarm, that means they're leaking somewhere. Very commonly, it's actually from the mask. Sometimes mask or tracheostomy that is malpositioned, or sometimes wear and tear. Sometimes the tracheostomy cuff is not fully inflated, it's leaking. It can cause leaks as well. For high pressure alarm, it's mainly blockage. Okay, blockage from secretions, malposition of tract sometimes, or sometimes if the patient is on this active humidification, then sometimes it's too humidified. Sometimes it can trap water in the circuit, thereby it causes high pressure alarm. Real case scenario, so this is same patient on tracheostomy ventilation in the hospital, active humidification here, and there's something wrong with the circuit. As you can see, the original heat moist exchanger is part of the circuit. I think it's a default circuit by the hospital, and it was put on by I'm not sure who actually put it on. And this is when the patient came out from the ICU, the HME wasn't there. Then it was connected to the active humidification. So yeah, one fine day, someone actually, I got a distress call that the patient is desetting. So on attending, actually, this HME is filled with water, it's wet. That's why it causes high resistance and reduce in ventilation. So instantly removed, everything went well. So important, if you have an active humidification, should not actually put a HME there. Okay, some factors, let's go into that affects tolerance and adherence. Airlicks is important. There's intentional or unintentional. So intentional is where the exhalation valve function. For unintentional, is like it's leaking from the side of the mask. Why is it important? Is because it can actually cause premature triggering because there's leaks, right? And with this, it causes patient ventilator asynchrony, and it also causes ineffective ventilation. So with this ineffective ventilation, asynchrony, it disturbs the sleep of the patient and the partner itself. And not just that, sometimes air leak itself, when the air is blown to the eyes, it causes eye irritation. So some solution is some new NIVs, they have very good leak compensation. If the leak is not too big, it should be able to compensate. Yep, as I mentioned, make sure the mask is appropriate, do proper mask fitting. And if everything that you have done is still there's a lot of leak, there's no other type of mask, maybe it's leaking from the nasal bridge area, which is quite common, then you can apply like foam pads like this. If your patient is prefer a nasal mask, doesn't want a full face mask, but maybe a mouth breather that leads to reduction in ventilation, you can maybe apply a very light chin strap so that there won't be a mouth leak during the night. And this is the beard and the denture. Yeah, this is something that you should look at if there is always leak, because this is always a factor that causes air leak, quite common. Yeah. Now, some example, you can see from the photo here, the beard itself causes the poor seal between the mask and the patient's face. This mask is too small. If you follow my cursor, this mask is too small. It's above the patient's lips, all right? And this is a fit test that I do. After I fit the patient on the mask, I generally ask the patient to tilt the head up, tilt the head down, left and right, and check where is the leak coming from. Once after I detect if there's a leak, the opposite side of the strap, I try to tighten it more. Yeah. For example, if you can hear this. So I play again, you can hear the leak is coming from the bottom of the lower lips. Yeah. So one of the options is actually to try to adjust the knob over here so that the mask will be fitted more towards the lower part. But basically, this patient's leak issue sorted out because the mask is also too small. I changed into a bigger mask and everything actually soft. Okay, the other thing is we commonly see is pressure sores. Okay, could be due to poor mask fitting, over tightened straps, prolonged usage, right? Because of the friction of the mask on the skin as well. Allergies can happen, whether it's silicone or gel, depends on the patient. This is an example of the patient developed allergy from the mask. So some solution is do proper mask fitting again, ensure all these contact points are checked daily by your caretaker, reduce the mask pressure, sorry. And if your patient can tolerate a few different type of masks, do a mask rotation, okay? Especially, I think in the acute setting, I tend to do a lot of mask rotation. Yeah. The other things that actually can affect the adherence of NIV, example like bronchocongestion, secondary to impaired cough. This is a full topic by itself that, because of very weak cough, then patients do become very chesty. So solutions is initiate these airway breathing techniques as early as possible to help them to clear secretions. Excessive salivation, imagine if your patients are using NIV at night and there's a lot of salivation that can actually affect it as well. So you may want to try some atropine drops. I used it quite common, quite frequent, it helps. Some very small evidence, you may want to consult neurologists for botulinum toxin injection of the salivary gland. Undernutrition secondary to poor swallowing or swallowing disorder can happen. So you may want to initiate early pack tube feeding. That's one of the solutions. In terms of gut issue, very common as well. Patients may tell that they find the stomach is bloated, they feel nauseated, there's reflux symptoms. This is what we call bloated, it's called aerophagia. Right? Solutions are like you can try, I think this is on the ResMed machines, they have this expiratory pressure relief. You can try lower mean pressures. Beware that if you reduce the pressures, your ventilation may drop as well. You can try switching over to a nasal mask. One thing that I've tried seems to be quite useful is to prop up the patients, and ask them to use 2 or 3 pillows to sleep at night. Medication, well, I've tried it. I'm not too sure whether it works, but some small reports do recommend it. Dryness and irritation, very common as well. So imagine if your NIV is delivering air into the nose, especially. Sometimes if this strong flow of air or is cold, it actually stimulates mucus production at the turbinate area, okay? And it blocks up the nostril. And of course, it will cause a lot of discomfort to your patient. So very important, adjust the humidifier and the temperature to the patient's comfort. If that doesn't help, you may want to use some decongestion, antihistamine, saline nasal wash. It does help as well sometimes, yeah. Okay, compliance issue is very important. So if you follow me here, roughly, this is I think the lifespan of the patient. If the patient is using NIV religiously compliant, the lifespan is long. Once there is leak, there's poor compliance or there's obstructive events, you can see the lifespan drops, right? So all these studies have demonstrated that if your patients on NIV, either they use it well or not being followed up, results not being monitored, it will lead to very, very short survival. So not just that, the poor quality, poor survival, not just that, even in fact, leaks and obstructive events are associated with increased mortality. So it's important to look at all these issues whenever your patient comes for follow-up or you're remotely monitoring them. Okay, just 2 slides before I end. Telemonitoring is available now. It's quite new in this part of the world. Like this photo, you can see I'm doing like a tele consultation with my home care provider there. We are doing a mask fitting for the patient. And these are all available platforms that you can use. And you can actually get more information from the brand of the NIV that you are using. So very useful, especially during the pandemic, from the platforms that I mentioned, the care platform. You can actually track your patient's report. You can actually look at their waveforms, right? And I use this platform to communicate with my patients every day. It's called Google Hangout. So I chat with them every day. Sometimes they send video clips of how they sleep at night so that roughly I can sort of know what's going on. Sometimes it's good to provide some feedback to your patient as well. This is like a feedback to my patients. I explain to them how's the sleep report overnight, what's the good thing. You see, this is probably a DSET there. This is what they provide me. My home care providers, they show me what's the setting, how's the patient fitted on. This is another patient that shows she has some conjunctivitis from the air leaks that happen. So it's a good platform to provide constant feedback. Yeah, before I end, I'll take this opportunity also to highlight, make use of this. Okay, not me. Take this opportunity. I think our colleagues from Tan Tock Seng Hospital in Singapore, they have done this phenomenal work in creating this app that has everything that you want to know about home band. In fact, they have a YouTube channel that is very comprehensive. Everything that you want to know is all available. So I fully encourage that you can actually get a lot of information from there. So with that, I thank you for your attention. This is a photo that we took 2019 during our first workshop in UM. Hopefully when the pandemic over, we will have another workshop. And I also like to take this opportunity to acknowledge my tremendously helpful home care team and the Philips Healthcare team as well that has greatly assisted me in terms of technical aspects of NIV. Thank you for your attention.